Hello, everyone. Welcome to week five. As you know, we have a test during our class time today. So I thought I would just do a little lecture on some of the slide presentations we have for this week. So I'm going to go ahead and start and share my screen here. So this week we're learning about psychotropic medications, medications used in psychiatry, and also substance abuse and treatment. So chapters 11 and chapters 18. Okay. So I'm sure we've all given a psychotropic med before. A lot of my patients have PRNs at least. If they don't have scheduled medications throughout, I find them to be very effective. We don't use it unless we absolutely have to, and these are more like your loxapine and olanzapine and stuff like that. But Okay. So psychotropic medications, they're drugs that alter brain chemistry. It influences like how we think, how we feel, and how we behave after we take them. It's used, of course, in modern psychiatry, mental health nursing, but as we know, it's not really a cure on its own. Works best when combined with psychosocial support groups, like if they have access to counseling, CBT, interpersonal or family therapy, psychoeducation, if they have healthy sleep habits. We all know how important sleep hygiene is for your overall mental wellness. So we have to ensure that patients have like a full holistic approach with their treatment plan. So biological, psychological, and of course, social needs. So the biological approaches are they rely on our understanding of how the brain chemistry works, how the neurotransmitters work, and how the receptor activity works. So, for example, lots of medications act by balancing serotonin or dopamine, sometimes norepinephrine. However, the research in psychiatry is constantly evolving. I see treatment plans changing all the time, where what we thought was best practice has now been changed to something else. And usually it's the old medications, they had a lot of negative side effects. So as we're going into newer territory, there are less and less side effects with these new medications, but there's still something we have to watch for. So, um, things that factor biological is like genetics. Your environment plays a factor, and your brain structure all play a role. Also, sleep is quite important. Sleep, everything around you. Okay, so the classes, the function of the brain here. Okay, sorry, I had to stop sharing there for a moment. Okay. So there are five main classes of psychotropic medications. There's antipsychotics, anti-anxieties, antidepressants, mood stabilizers, and then there's stimulants. Each class has distinct mechanisms and side effects, but they all share the goal of improving quality of life. Um, you know, less disruptive symptoms, better balance overall. So keeping in mind that we have two responsibilities as nurses, understanding how these medications work and to support the patients in managing side effects and adhering to treatment. Some are very, like the patient complains of a dry mouth. I know it's not fun, but if you look at the risk versus benefits for that one, when it comes to like your cardiac health, that's something completely different. But little things we can support them through, like just having a cup of water at the bedside or have a cup of ice at the bedside. So antipsychotic medications, they're primarily used to treat psychosis, symptoms such as like hallucinations, delusions, extreme confusion. Sorry, got pop-ups on my screen here I'm trying to get rid of. They can provide rapid relief during an acute episode. That's more of like what I see, unless they have behaviors that are consistent with this medication around the clock. That's different, but sometimes, they just need to, sleep and rest and relax, and this is where this comes in. Because sometimes they're at risk of harming themselves and sometimes they're at risk of harming us. And so, all of our well-being is more important than then we're waiting it out and potentially being hurt. So these medications, typically, if they're taking on a regular basis, they usually take about 4 to 6 weeks for their full therapeutic effect for them. We also try to aim to reduce the symptoms without overwhelming the patient with side effects. So we, as nurses, work as educators. We help them and their families understand why continued use, even when symptoms improve, is essential for long-term stability. And I'm sure you guys have all seen, I've seen tons of it where I have the patient feels better, stops taking the medications, and all of a sudden they're into an acute episode again and having to start over and get them into a better place. Okay, so I think we talked about, antipsychotic medications are good. However, they're also best to be used with some kind of therapy. If it's like family therapy, how to cope with things if something is bothering them, if they hear things or see things. So having to kind of help them, link to resources, advocate for them, make sure it's patient-centered care and the whole family is involved. If that's what the patient wants. I always have that issue where the family are very much involved, and I kind of take cues from the patient. Sometimes I ask the families if I could just speak to the patient in private for a moment, and then I ask them, what do you want? Because I'm happy to put them in a situation that makes them feel more comfortable, by removing people for a conversation or for treatment or whatever have you. We have to work as our patient advocate is number one. So, side effects is one of the biggest barriers to adherence. Common reactions are like, oh, the weight gain. That's another one that people are really worried about. Sometimes they're sedating, so if they take them that night, that's great. But if they're sedating and they have to take them twice a day, that isn't the greatest because they're going to be so tired in the mornings after they take their meds. So that one, weight gain's another big one. You can put them into like a metabolic state where they're, at more risk of developing type 2 diabetes and everything else that comes with like abdominal, mostly weight gain or just weight gain in total. Some side effects will lessen over time, but others, such as like tardive dyskinesia, so that involves involuntary movements, maybe permanent. So we need to provide the patients with education and just reinforcing the importance of reporting side effects so we can work together to change doses or medications. It gives the patient a little bit more power to feel like they are part of their healthcare. Okay, so another one is extrapyramidal symptoms, so EPS. Results from the dopamine blockage in the basal ganglia. So it's responsible for motor control. Symptoms can range from restlessness, muscle stiffness, to severe involuntary movements. First generation antipsychotics are most strongly associated with EPS, but second generation drugs can also carry that risk as well. So kind of make sure we watch for it. Treatment includes medications like Cogentin. I remember the first time I had a patient, I was a student. I was in my RPN student, and I was in adolescent psych. And seeing this, I was like, oh, well, what do we do? Because I had no idea. I didn't know this happened with medications. And the poor kid, he was probably 10, was just terrified. But we gave him Cogentin. He seemed to be better, and then had to sleep it off as he tried to process everything that just had happened. So as long as we recognize the early signs, educate the patients on what to watch for, and then advocate for interventions if the symptoms become overwhelming or especially disabling for the patient. Scroll in here, some symptoms there. Okay. So neuroleptic malignant syndrome, it's rare, but it's life-threatening complication of antipsychotic use. Symptoms include sudden fever, muscle rigidity, altered mental status, unstable blood pressure, or heart rate. So it's a medical emergency, requires immediate discontinuation of the drug and intensive supportive care. So nurses are usually the first ones to recognize the symptom that the patient is like slightly getting warmer or like early warning signs. Blood pressure's out of control, so we need to stay vigilant in this case. Um, even though the risk is low, the stakes are very high. And I will tell you a story. So I had a patient who went from 36.5 to 43.4, I think, in the matter of 4 hours. And we were like, no, like, he felt hot, but you're like, no way. He had, excuse me, one dose of Seroquel, 25 milligrams. And so he developed serotonin syndrome and left epileptic syndrome. Blood pressure was, at 200s, heart rate was 170. It took a while, and for us to treat, it's just the symptoms that we treat until we can like have the medication removed from the system and they will hopefully recover. But as you know, like having high blood pressure and the heart rate compensating for like trying to perfuse the whole body with that, it's difficult. There can be lasting effects, but recognizing it, stopping the medication right away, even if you think it might be this, best to just, talk to the physician and see should we continue and what do you think? A couple more things here. So typical antipsychotics, the first generations, such as like Haldol, chlorpromazine, that's an old one, work strongly by blocking dopamine receptors. They're effective in treating positive symptoms like hallucinations, but they do very little for negative symptoms with social withdrawal. They're also more likely to cause EPS and cardiac effects like the QT prolongation. So if you have a patient who, my patient's on the monitor, I can see their QTs. If it's getting longer and longer, I'll, do an ECG to verify. So if you have a patient who you think is at risk of having a QT um, prolonged, then I mean, it's not wrong to do an ECG just to confirm that. So we're looking for heart rhythms, watching for like motor side effects, and supporting the patient with education about compliance. Chlorpromazine, that I think I've given that once or twice. Like it's not common. And again, they have lots of side effects. So we don't tend to use it. And I think it was given for nausea as one of the off-label things. And this was like 20 plus years ago. So it's been a while since I've actually given it. And then Haldol, I mean, it's okay. It does work. It works very well for nausea at a lower dose. So I do give that. But if I'm giving like 5 or 10 milligrams of Haldol IV, I'm not wanting to do that more than once. Like I would want to have like a second generation or something else that's less damaging to the body. Okay. So let's see. So also the second generation antipsychotics. So this is things like risperidone, olanzapine, quetiapine, or Seroquel, target both the dopamine and serotonin receptors. So it means that they can help with both positive and negative symptoms, unlike the first generations. But these again, they do bring challenges of like weight gain, especially in abdominal girth, which puts you at risk for diabetes. Um, so keeping an eye on their blood work, they should really be having blood work every 3 months for this to just to check their A1C and make sure that it's okay. But you can usually tell if they're like gaining a lot of weight in the belly. Yeah, just checking their A1C and seeing what their sugars are looking like. Okay, so anxiety medications. So benzodiazepines, they act really well. They act quickly, and they're used to treat acute anxiety and panic. Also, I've seen them given for sleep, to relax muscles, also given them to prevent seizures. So it's life-changing in crisis situations, but it's not intended for long-term use because of the tolerance and dependence risks. So as nurses, we need to just kind of look at that and making sure that they're being used properly, so say the patient is at home and understanding the risks. So, benzos are quite commonly prescribed, widely used, and widely misused, unfortunately. Patients should be encouraged to try non-drug approaches such as like relaxation exercises, yoga, mindfulness. We know how to do that. We use that all the time, right? Um, So helping them to kind of identify healthy coping strategies and reinforcing that medication should complement but not replace these long-term practices. All right, so benzodiazepines, they enhance the neurotransmitter GABA, so it dampens nervous system activity and produces calmness and sedation. So they're used for both anxiety and insomnia. However, the same mechanism can also cause oversedation or impaired coordination, can make them at risk of falls, especially if they take it at night for sleep, and especially for older adults. So always assessing like the patient safety, if they need a walker, do they need like to get up with slippers that have um like the treads on them that we use so the patient doesn't fall, all these things that we can kind of look at. So common examples of benzodiazepines that we would probably give quite a bit is lorazepam, Ativan, um, clonazepam, diazepam, and in the States they use alprazolam a lot more than we do. We do sometimes, not a lot, and another one that I use quite a bit is midazolam, and that's more for like it's quick and dirty, goes in the system, works effectively, and then it's gone pretty quickly. I know Ativan has like a really long half-life, and the midazolam is not as bad. So we do use that instead of like propofol for sedation, but we also do it if we need to do like a little procedure or if my patient's not breathing properly, just to kind of like relax all the muscles. That was something that we would use. So, like I said, they all have different half-lives. So it can be more suitable for either short term or long term, depending on which one it is. Another one here, zopicone, sometimes prescribed for insomnia, it has similar side effects. So just kind of making them understand the difference between that. And I think the worst thing with well, zopicone does have an effect that you can go into like a you're unaware and you're sleepwalking and doing things that are unsafe. But it also causes a horrible taste in your mouth, and most patients don't like it, and sometimes don't take it because of that. Just scrolling a little bit more. I think I just talked to that. So side effects. Common side effects are, of course, drowsiness, dizziness, confusion. At higher doses, patients might experience difficulty breathing or significant memory problems, which is good for midazolam because that's the one we give for like a procedure for colonoscopies, for reductions, for like setting bones. We give people midazolam. And orally, it's a lot different than what you would give like IV. Um, I know like IV, we usually give like 1 to 5 milligrams. Orally, my daughter was maybe 70 pounds and she took like 30 milligrams. So it's very different. At first I was like, what? But yeah, no, it's different for that. Also making sure the patient's not taking it with other medications that can sedate them. So like if they're using these street drugs, if they're using sleeping pills and antipsychotics, just to kind of warn them about the risks of falling or anything that's more sedating. So benzos should only be prescribed for a few weeks at most. Long-term care of these sometimes increases tolerance dependence and you'll have a withdrawal as well. So another thing I would want to mention was the use of like the CWA protocol. So we use, we score them to see how they fit on the alcohol withdrawal scale, and then we'll give whatever it says, like the patient is scored, whatever the score says, we would either not treat or treat. And with that, we're kind of looking at like symptoms of hallucinations, tactile feelings, their vital signs, their sweating, nausea, all sorts of things to kind of watch for. And I find that we give those people a lot of benzos, like Ativan, I think it's 4 milligrams IV that I would give in one time. And diazepam's the other one that we give for that, and it's usually 10 milligrams. And after a while they'll wake up without symptoms. So hopefully it'll be effective in treatment for that. Okay, so dependence and withdrawal, really, dependence can develop quite quickly, especially in higher doses. And withdrawal symptoms that you might see might include like a high anxiety symptoms, which the drugs are kind of meant to treat, which can make stopping these meds a little bit difficult and challenging. Severe withdrawals may include seizures. If that's the case, then we need to obviously not go as quickly, removing the medication from the patient's system. So if we think there's an issue, let the doctor know they might want to do it in a more gradual reduction of doses. Okay. And then antidepressants. I feel like this is all things that we know, right? So antidepressants are used widely for depression, anxiety, bulimia, chronic pain, among others. Often take several weeks to show any kind of benefit. So it requires patience from the patient. Um, it will come, you will feel better. It takes time to work. I know it's also frustrating when they've been on different medications and they have to like remove that medication and taper it down to start a new medication and then wait the 4 to 6 weeks to see if that may become effective. So it's frustrating. We just need to hopefully get the patient to a happy place that they're feeling better. So the mechanism of antidepressants are they increase neurotransmitters like serotonin, norepinephrine, and dopamine, helps regulate mood, reduce stress. Approximately 70% of the patients respond positively, though not everyone benefits from this. Nurses should just prepare for trial and error and find the right medication, emphasizing, the importance of this. And I know it's frustrating, but we'll get you there, and this is how we get you there. So, side effects of antidepressants, nausea, headache, sexual dysfunction, sleep disturbances. That's along with like, dry mouth, it could be sedating, um, lots of things it can do. Just gonna scroll here. Okay. So SSRIs, that's typically what I would see as a first line for patients with any kind of depression or anxiety. So we're looking at like sertraline, fluoxetine. There's fewer side effects for those, but may cause sexual dysfunction or GI upset. Um, I I have seen patients become like almost ragey on SSRI, so having to back off on those because it didn't make them feel very nice. Then we have like SNRIs. This is used for depression, anxiety, and pain. In higher doses here, you have to kind of watch for hypertension. To keep an eye on that. NDRIs like bupropion, they're energizing, less risk of sexual side effects, and helpful for smoking cessation. That's been in the books for 40 years or so for an off-label use. And there's a risk of insomnia or seizures at higher doses. Drugs like mirtazapine can be very sedating, stimulates appetite, useful in patients with insomnia or weight loss. I know mirtazapine is also another one that causes a tremendous amount of weight gain, especially around the belly. Um, Sedating, I've heard different doctors say different things. Now I've heard them that, the 30 milligrams is the sleep dose, and then I've heard some say like 12.5. So they say it's more sedating at a lower dose, but and they come in 15 milligram tablets or 30. So I don't know. I don't know if that's what it is, if that's the way it works, I wonder. But yeah, we do give it. And then MAOIs we also give as well. So we don't use them a lot. There's a lot of diet restrictions and the risk of a hypertensive crisis when you eat the wrong things, especially like cured meat, which is, no more charcuterie boards. So I think patients would just be non-compliant in that sense if they were big foodies. So a couple slides here on all the medications. Okay. Yeah, so here's the MIOI diet. So no red wine, no cured meats, and no cheese, well, avoid cheese, can all lead to hypertension and severe hypertension. So, yeah, that would be your entire charcuterie board you cannot have. Okay. Others, I think I saw up here that St. John's wort, it can also cause serotonin syndrome if you're mixing that with like an SSRI. So when we talk to patients or if they're like coming in for an assessment, asking what medications they take, but also what supplements they're taking, because it could affect their well-being if they're mixing with them they shouldn't be mixing with. Okay. So mood stabilizers, they're essential for managing bipolar disorder, keeping patients from swinging between mania and depression, where antidepressants alone can worsen the condition by triggering the mania. So emphasizing the importance of mood stabilizers as the foundation of treatment and educate the patient that benefits may take weeks to appear, of course, right? Um, the one that was not, it used to be the biggest one used, lithium. That was more like early days. It used to be the only treatment for bipolar, and that's why it was kind of very popular. So it treats both mania and depression, but you have to really be careful and check their blood levels, thyroid, kidneys, because it can damage them over time. Yeah, can cause toxicity. Um, Valproic acid used to treat acute mania, having to watch liver function with that one, and then educating the patient about drowsiness and potential weight gain. And I've seen that one used quite a bit for seizures, or for my head traumas. And carbazepine. This is another one I see used for seizures as well, but it's also used for irritability and aggression, but it carries the risk of serious blood disorders. So we're looking for like sore throat, fever, mouth ulcers can cause that as well. And lamotrigine, it's effective for bipolar depression, requires slow titration in order to avoid a severe rash. Isn't it weird that all these all these meds cause different kind of side effects? Just gonna scroll a little bit here. So the duration of mood stabilizers, they're usually long-term care, like long for life, lifelong treatment. Once they're stabilized, they may be able to move to a maintenance dose. So, looking for consistencies in their taking their meds and encouraging regular blood work, reminding the patient to stop if they're having any side effects and to notify their care provider in that case. There's all the medications here. We're almost done this one. So, again, for St. John's wort, like I said, it can trigger serotonin syndrome, which is very closely like related to neuroleptic blood syndrome, where their temp rises, heart rate rises, blood pressure rises, all those things. So, making sure that they're not taking the St. John's wort with it. Okay, I'll stop my share, and that's it for this one. All right, just had to get the new slide up here. Okay. So this one, chapter 18, psychoactive substance use and treatment. So looking at substance use addiction treatment and how we do this. First we need to kind of understand how substance use disorders develop, the impact on the patient's health, and what is our role in assessing intervention and the recovery. So, is it addiction? Is it compulsive behavior? Addiction involves both psychological and physical dependence on psychoactive drugs, and compulsive behaviors, while not always substance related, share characteristics like loss of control, continuation, despite harm. So we have to kind of distinguish between the two, recognizing that when the behavior is substance driven versus behavioral compulsion, it kind of guides the way to appropriate interventions. So here we have a little Venn diagram. So we can see like that addiction develops through stages. There's experimentation, integrated use, excessive use, and finally addiction with tolerance and withdrawal. So this process is influenced by biological, psychological, and social factors. So understanding the addiction on a continuum helps us kind of tailor interventions where the patient is in their journey rather than seeing it all or nothing condition. So, every single patient is different, especially in mental health. A lot of times I get my, simple MIs, what happens with them. They're all the same. They get the stents, they get meds, and they get sent home. But in mental health, it's very, very different. Everyone responds differently to the different medications that are available. Okay. So the epidemiology behind it, alcohol remains the most widely used substance in Canada. It's 78% of Canadians over age of 15 reporting use. That is pretty big. I wonder if it's like a drink with Christmas dinner and that's it, or is it daily? I don't know. If it's addiction, of course, it's daily, but yeah, 78% of Canadians over 15 report alcohol use. Um, so opioids are definitely dominating the headlines. Cocaine use has seen the greatest rise. Fentanyl is another one. Oh my goodness, I can't even describe how horrible it is on people in the streets. It's just that's for another time, I suppose. So the epidemiology, so substance use is common across Canada, but the usage pattern differs by gender, age, and the region that you live in. So men continue to report higher rates of illicit drug use than women. And epidemiology kind of informs public health strategies and highlights the population's most at risk and guides interventions and resources to prioritize those patients that are at higher risk. So psychiatric comorbidities, when substance use is co-current with mental illness, it's called concurrent disorder. So commonly overlaps to include PTSD, mood disorders, and psychosis. Nurses must screen carefully for comorbid conditions, since treating one without addressing the other often leads to a relapse. So, I mean, lots of people have PTSD and they just don't want to talk about it. So kind of telling the patient you don't have to go into details, but do you suffer from PTSD or how do you think it is give them a scale. So medical comorbidities that we might see, alcohol use can lead to Wernicke's encephalopathy. It's acute, it's reversible, and then Korsakoff syndrome, which is chronic and often it is unreversible. So fetal alcohol spectrum disorder also has lifelong implications, and for IV drug users, the risks include hepatitis, HIV, cellulitis, vein damage. I would, the most thing I see for IV drug users is developing vegetations on their valves in their heart. So unfortunately, they have sometimes needing to get a new valve replaced. Um, and I have seen, I don't know if it's changed, but in the last 5 years, I had a patient who he had one valve replaced and then he continued the behavior and needed another valve replaced, and they said no. So I don't know if that's normal for you get one and that's it, or if that was just like a one-off case, but big risks to say the least there. Right. So the etiology. Addictions usually develop from a mix of biological, psychological, and socio-cultural factors. Genetics can predispose individuals, but trauma, mental health issues, and environmental stressors increase the risk. Think about like um, environmental stressors, like losing a job, losing a loved one, having to pay rent, and you don't have any money, like all sorts of things that can um, cause all this emotions to get really, really high. Those would be like your social, economic ones. Biological, of course, is genetics. Trauma is a big one, and I see this in like especially people who eat. I don't think we're going to talk about that behavior, but lots of people who have a lot of trauma from childhood, they turn to food instead of drugs and alcohol. And I don't honestly know which one is worse. I think they're both damaging, but okay. So for our assessment, covering both substance use patterns and related health issues here. So we're checking the blood alcohol level, checking the cage screening for alcohol use. Like we talked about SIWA in the last presentation. So that's for alcohol withdrawal, and then cows for opioid withdrawal. And of course, all of these are done just to make sure the patient doesn't have any seizures or they're not at risk of developing any issues. I've seen lots of patients come in who have tried to quit alcohol at home by themselves and they've had a seizure and had to come into the hospital for it. Some have permanent damage, others turned out okay, but we never do know, right? Okay, so key areas for comprehensive assessment. There's four cage questions, cut down, annoyed, guilty, and eye opener. So those are our quick screening tools for alcohol use disorder. So a single yes answer would suggest further evaluation. And then we should really be familiar with using these tools in order to have routine practice and sensitive to how patients may respond to these questions we're asking them. So there's some examples of your cage assessment, you know, annoyed, guilty, eye-opening. So have you felt you ought to cut down your drinking, substance use, or behavior? These kind of questions that we ask them. Okay, and then acute chemical impairment. When assessing a patient in acute intoxication or withdrawal, nurses must prioritize safety. This includes assessing for severe withdrawal or overdose, screening for suicidal thoughts, identifying medical complications, and exploring motivation for change. And that's a really big one. Sometimes it's like, I know my wife is going to leave me if I don't stop. So, or my children don't want to talk to me, or something like that. Um, so our assessment here would guide like immediate interventions and also determines the level of care that this patient might need. So signs of intoxication and withdrawal. Um, Different classes of substances will present differently. CNS depressants would be like alcohol, opioids, benzos. They may cause drowsiness, they may shallow breathing, and withdrawal delirium. Um, Breathing, I it does. If they're breathing, I say eight is usually a good number for a grown man, to do a proper exchange of respirations and their breathing. But anything less than that makes me a little bit nervous. Um, Stimulants like amphetamines or cocaine, those produce agitation, elevated heart rate, and paranoia. And what I see of patients with this is they've had a serious cardiac event from the cocaine or amphetamine. So their heart was just, it couldn't keep up with what it was trying to do. And then cannabis, hallucinogens, inhalants, it causes perceptual changes and can impair your judgment. So we need to just recognize the patterns and provide safe care during a detox with the patient. Okay, so helping patients change. Supporting them means more than just like detoxing them and getting them to a safe place. It's kind of helping them move through the psychological stages of change. So self-awareness, self-assessments for the patients is very crucial. We have to guide the patients to kind of recognize their own patterns and develop motivations to change rather than imposing change upon them. So, making the patient feel like they're the ones that are making the decisions to stop. We're just asking, what you have to lose if you do not stop. We can't say you're stopping, let's go, because that would kind of not be a very good rapport with the patient. So, the trans-theoretical model of change, it describes the behavior of the behavioral changes. So pre-contemplation, contemplation, preparation, action, and maintenance. So we tailor interventions to the patient's stage and then avoid pushing them too far too fast because relapse is common here, should be seen as part of the process rather than a failure. So a lot of patients will say two steps forward, one step back, but they're still moving forward. So, we're getting there. Motivational interviewing. So, Miller and Rolnick's 8 steps for motivational interviewing emphasize rapport, identifying ambivalence, and eliciting self-motivational statements. So, as nurses, we can use this to strengthen the patient's own reasons for change rather than arguing or lecturing the patient. So, its approach is collaborative, it's respectful, and it makes the patients feel empowered in their recovery journey. Okay. So as nurses, we will these are diagnoses to have like impaired coping, risk for injury, ineffective denial. Outcomes will focus on withdrawal stabilization, active treatment and engagement, and long-term health maintenance. So planning is very individualized, and we're considering all of the patient goals at the same time, the readiness of the patient, and the support systems in place for that patient. And I cannot stress that enough. The patient needs somewhere safe to live, have support from family. If they do not have any of those things, there is higher risk of a relapse, and it doesn't put them in a very safe place. Okay, so the implementation pharmacological support. We can provide them with methadone for opioids. We have medications for alcohol withdrawal, and then nicotine replacement. We can give them the patch. Of those, I can give with an order. The smoking patch, the nicotine patch, we now do not need orders for it at my hospital. So maybe yours is the same. If a patient comes in and they're a smoker, they're getting a patch. That's just it gets them help them through the kind of phase of withdrawing from nicotine. And then also psychosocial interventions like group therapy, peer support, counseling. We have to balance medication management and also therapeutic communication as well. So levels of prevention. Um, Primary prevention would include like education, labeling policies, taxation on alcohol and tobacco. Secondary prevention is harm reduction, like supervised injection sites, and that would be a really cool topic to kind of talk about in class because everyone has a different view on this. I'd like to hear everyone's side of their views. But anyhow, supervised injection sites, we have managed alcohol programs and relapse prevention support. And then tertiary prevention, we're looking at detoxing the patient. They're going to rehab and we're giving them recovery services. So as you can see, we're involved in all of these, primary, secondary, or tertiary. And then the nursing process for evaluation kind of focuses on whether the patients are meeting treatment goals and whether interventions need adjustments. So, as nurses, we need to monitor for relapse risk, assessing progress, and maintaining a supportive therapeutic environment. So, consistency, optimism, and flexibility are key here. Then we have just a question to go through, and there's the answer if you had a little look there. So I'm gonna stop sharing my screen. Um, no, I lied. I'm gonna share my screen again. Okay. I just wanted to kind of go over what else we have for this week. So there's our readings, chapter 11, 18. There's some supplemental readings there, but these videos are fantastic. Where are they? Oh, I also have this here if you're interested in it's kind of a quick and dirty one. Like kind of like my notes that I post every week. Nope, nope. Yeah. Okay. So here we have psychiatric medications, anxiety medications, antidepressants, and then bipolar meds. So this is really good. I like that, like I'm a visual learner. So if I see it, I hear someone talking about it and I can see it being done, it makes more sense to me. So great videos to watch as well. And oh yeah, I put some not helpful now. I did post an announcement, midterm practice questions that we're gonna have in about half an hour when the class is starting. Yeah, so they're here if you want to use them, and you can use them again when you study for like the final where it's a comprehensive. But yeah, okay. So now I'll actually stop sharing my screen. So I think that's it for this week. And if you have any questions, you know where to find me. Please don't hesitate to reach out. Bye.